Welcome to you all. It's great to have you here at a Friday afternoon. It's raining a lot here from Brussels, but I'm very happy to have you here in, I would say, one of the most important sessions of Gastein on a topic that's very close to my heart, because we are going to look at health inequalities and mental health and how COVID-19 has impacted on it. So I'm Caroline Costons and I'm the director of EuroHealthNet. EuroHealthNet is a European partnership to improve health and well-being in Europe. And we have many national public health institutes, regional authorities, and academics. Overall, we have about 65 organizations that we represent. The session is organized by EuroHealthNet, by the Health Foundation, and also by the Trimbos Institute. And the Trimbos Institute is the Netherlands Institute of Mental Health and Addiction. They work on mental health, on enhancing quality of life of people in the Netherlands and beyond. So we are very pleased to have this session here together with all of you. And now I would like to hand over to my co-chair. My co-chair is Tim Elwell-Sutton, and he's the Assistant Director of Strategic Partnerships at the Health Foundation. So Tim, the platform is yours.
Thank you very much, Caroline. Yeah, a big welcome from me as well. This is, I think, such an important session. The Health Foundation is a UK-based independent charity, and our mission is about improving health and healthcare across the UK. And we have quite an extensive programme of work now on health inequalities and the wider determinants of health. And we're very pleased to be partnering with EuroHealthNet on this, and also with the Trimbos Institute. So we're actually going to start the session with a bit of a warm-up and a chance for you to be involved. We've got a poll where we're going to ask you just 3 questions, and you'll get a chance to vote on them. Now, the questions should pop up right in the middle of your screen, but if you do miss any of them or you don't get time to answer, you should be able to go back to them on the right-hand side of your screen in the polls tab. So I'll just start to talk about some of the results as they come in. So that first question, it says in August, under 12% of financially secure people in France reported anxiety. What percentage of people in very difficult financial situations felt anxious? And there seems to be a universal agreement on that question, that the answer is the highest proportion, which is 31%, and that is the correct answer. So I suppose what we're trying to illustrate here is the very significant gradient that we see in reported mental health difficulties, and I think that's true across quite a number of different measures. The second question relates to the NHS in the UK. So 44% of doctors and dentists in the UK are Black and minority ethnic groups. What proportion of mortality from COVID-19 within the NHS do they make up? So the majority of people there have gone for B, which was 63%. I'm sorry to say the answer is actually 95%. So it's hugely disproportionate burden has fallen on minority groups in the NHS. And I think that a lot of that is to do with the types of roles that they do. And the final one, in the UK, 50% of male workers with higher education can work from home. What percentage of single mothers with low qualifications can work from home? And I think everybody's got that one right. It is the lowest proportion there of 12%. And I think for me that highlights one of the things about this pandemic, which is I think it is amplifying existing inequalities which we knew about beforehand. But I think it also may have some unexpected effects and potentially create some new inequalities for groups who we haven't spoken about in the past. So thank you very much for taking part in that. That was the warm-up act. I'm going to pass back to Caroline now for the first speaking session.
Yeah, so thanks a lot, Tim. I also think these figures are pretty shocking. It's not only how COVID-19 has the potential to exacerbate health inequalities, but also how we should look at COVID-19, not only as a pandemic, but as a syndemic, as was mentioned by Claire Bambra and Richard Horton in The Lancet. Because COVID-19 is magnifying really the inequalities that are there. The severity of COVID-19 is much stronger due to these inequalities and due to also the high burden of non-communicable diseases that are interfering, let's say, with the disease pattern of COVID-19. But let's now go to our speakers, our experts, and I'm very happy to introduce to you first Nico Dragano. Nico is a medical sociologist and he has expertise in occupational epidemiology. He's a professor for medical sociology at the University Clinic Düsseldorf and head of the Düsseldorf School of Public Health. His main fields of interest are psychosocial risk factors at work and digitization of work and health and social inequalities in health. And we've asked Nico to sort of set the scene and tell us indeed how is the impact of COVID-19 on health and health equity in particular. So Nico, the floor is yours.
Thank you very much, Caroline. Thanks, Tim. Can you hear me?
Yes.
Okay. Hello, everybody. I'm a social epidemiologist and involved in several research projects. So I will talk as a researcher now to open the session, and I will talk about the broader health consequences of the pandemic or the syndemic, as Caroline said. And I will start first with the burden of disease we expect in the course of the pandemic. And it's not only about COVID-19, but also about indirect effects. And after that, I will close my talk with some comments on health inequalities in those health effects. To start with the health effects, we distinguish direct and indirect effects of the pandemic. The direct effects are diseases related to the virus, which is the number of infections, the number of severe disease, and the number of deaths. And we already see a very high burden of disease. Yesterday, 34 million infected persons around the world, 1 million deaths. So it's a considerable burden of disease when you look at the direct effects of the pandemic. Another point which we see now as a direct effect are prolonged symptoms. We see it's not over when people get recovered. We see that they show symptoms even months later. So we don't know if we got a high number of those delayed effects. The other more indirect health consequences, I try to make 3 points. The first one is the mental health burden, and you are all experts of this. The whole situation is very demanding. There are several new stressors, for instance, the fear of getting infected, and we got a step rise in the number of people who feel socially isolated, and social isolation is a well-known risk factors for mental and physical disease. And it's strongly related to things like quarantine and social distancing. So this risk factor is very present at the moment, and it can be that we see a high number of mental disease following this phenomena. The second indirect effect is the economic crisis. Already seen in many countries or coming up. And we know from previous crises, the debt crisis in 2008, that economic crisis is always related to worsening population health. For instance, in the 2008 crisis, we saw in many countries an increase in the number of mental diseases. We saw an increase in suicide and several other effects, even on physical health, but economic crisis impacts mental health very strongly and very quick. The physical health effects have a certain delay, but we even saw increasing number in CVD or things like that. The third point is related to healthcare and healthcare utilization. In particular, at the beginning of the pandemic, we saw that healthcare utilization went down. So, for instance, in our clinic, there were no patients with infarction anymore. And I don't think that the people don't get ill anymore, but they didn't want to go to the clinic because they had feared to get infected, or the healthcare providers themselves, they had regulations holding people of taking their regular visits. So we also saw and see a healthcare crisis, and in particular in psychiatric care. So we got direct and indirect effect in a large extent, and now I will close with some comments on social inequalities. All those effects, the direct ones and the indirect ones, when we look at the evidence we already have from empirical studies, will hit people with less resources harder. That's very, very clear. We see in many studies that the risk of getting infected is higher for poorer people, for people in precarious employment who can't stay at home, for instance. We had one question in the poll: who can stay at home? Privileged people with good education. Others can't. So we see inequalities in the direct burden of the pandemic, and we for sure will see them in the indirect effects. When you think about the health effects of an economic crisis related to unemployment or fear of job loss, so it's very easy to imagine that people in disadvantaged positions suffer much more. So we believe, and we already see it in the data, that health inequalities will increase. And the question is now, what can we do to mitigate it? But that's part of the discussion, I guess. And in the discussion, I can also comment about the mechanisms. How are social factors related to direct and indirect effects? Because I think it's very important from our side, from the research side, to inform you about the mechanisms in order to decide which measures will help. So that's from my side. Thanks a lot.
Thanks a lot, Nico, for your great overview and an important start of this session. I would like to remind the audience that you can ask questions in the Q&A. We will do a short Q&A session after 3 speakers have spoken, and at the very end of this session. So please do ask your questions. Thanks, Nico. And now I would like to go over to Ghazal Amir. The theme of Gastein is dancing with the elephants in the room. And we feel that there is an important elephant in the room, and that is the issue of racism, of discrimination. And already the question in the poll that we asked you about the number of Black and minority ethnic doctors, how much they suffered and died much more than white doctors. I mean, that is a disgrace. And there are many underlying problems here. And I look forward to hear from Ghazala how your perspective is on this. And just for all of you, Ghazala has some IT problems, so she will using her phone to speak. So I hope it's going to work well. Ghazala, the floor is yours.
So, well, the evidence on COVID-19 and ethnicity, where it's being collected, shows that there are huge differences in health risks, both in terms of higher rates of death and at a younger age in minority ethnic communities, rates of admission to intensive care units, rates of illness, and the economic impact is much more severe within minority ethnic groups. And these are all historic inequities, but that have become more apparent and exacerbated as a result of the pandemic. And specific groups have been particularly highlighted in the data. So Black communities in the US and the UK have been specified. Bangladeshi, Pakistani communities in the UK, which we know are proxies for Muslim communities. So there are overlaps with religious discrimination. asylum seekers and other migrants. Within the NHS research that has been done, Filipino ethnicity has been an issue. And across the European Union, the Roma population has been highlighted as experiencing particular exclusion. And I think we need to understand this phenomena as at three different levels. First, in terms of the social and political discrimination and marginalization that happens to these communities, where there is entrenched structural racism.
Yeah,
Can you hear me okay?
Yeah, perfect.
Yeah. Okay, so entrenched structural racism, non-representation in policy making that can lead to a hostile and punitive policy environment. This can lead to restricted access to healthcare for migrants, things like charges for COVID-19 tests, for example, even. Media and social media blaming for people, not just of Chinese or apparently Chinese origin, but across the board, there are different communities being blamed for spread of the virus. And in terms of policy making, sometimes, and even in research, a focus on genetic and cultural explanations, or things like vitamin D deficiency, for which there is much less evidence than the evidence on entrenched structural racism, that these are often focused on as to explain the inequities that are happening. And of course, in some contexts, there's a lack of data altogether on ethnicity. So there's an invisibility of those communities that are experiencing this exclusion. Now, that context at the social and political level impacts on institutions, and there is systemic discrimination in employment, and including within a range of public services that affect health. So things like healthcare itself, education, housing. We find that people are employed in those areas, in areas that give them a higher exposure to risk. So public-facing roles, as Nico was saying, people less able to social distance or work from home, in lower status jobs where if there is discriminatory practice, they're less able to challenge it. So things like access to protective equipment. We know within the NHS that this has been an issue, people being put into wards to treat COVID patients are more likely to be from, they're more likely to be staff from minority ethnic communities. And precarious employment and lack of government protection. And then in terms of the policies for lockdown themselves, there can be targeting for punitive kind of enforcement of those policies. So within healthcare and housing policies for asylum seekers, we see people crowded together, the use of police surveillance and force. We know that Black Lives Matter is not a new phenomenon. There has been police violence has been something that has historically been experienced. And then data sharing between healthcare and immigration and between criminal justice agencies and healthcare means that people often don't trust those services. And all these issues at the macro and meso levels have an impact on individuals and communities, where this sort of social exclusion can lead to socioeconomic disadvantage. And we know there's a high association between mortality and deprivation, more likely to be infected because of issues, or more likely to experience worse outcomes because of issues like long-standing illness that have historically been higher within disadvantaged communities, overcrowded housing, homelessness, and then issues like health literacy and digital exclusion, which also impact on people's ability to protect themselves from the pandemic, and the mistrust of services that I've mentioned. Levels of stress within these communities can be really high, high levels of fear, anxiety, and isolation. And these inequalities persist even after adjusting for socio-economic and clinical factors, which are themselves outcomes of structural racism. So racial discrimination has been described as the single underlying cause of ethnic inequities. And I call them inequities because they are avoidable and they are unjust. It's not just disparities. We're talking about things that actually could be avoided. These inequities are, simultaneous processes across a person's life course and transmitted between generations. And what the pandemic really brings home is how the safety and well-being of minority ethnic and religious communities is connected to everyone's safety and well-being. If one population is more exposed to the pandemic, then other populations will suffer both locally, nationally, and globally. And so the solutions have to address these macro, meso, and micro level causes of risk.
Thanks, Ghazala, for pointing this out to us, and the systematic discrimination as the underlying important main factor, and also how everything is so interrelated and multifaceted, and it is clearly a super important determinant that we have not sufficiently addressed in health policy at all. And I look forward to further discuss it later in the session. So thanks, Ghazala. Now we move to Laura Schultz-Zeeman. Ghazala, I now note that I haven't introduced you properly, and I want to do that because that's really a mistake from my part. So Ghazala, we just heard from her. She is Associate Professor of Health Equity and Inclusion at the University of Leeds. Interest in service development for those underserved by health and other public services and those seldom heard in decision-making about health policy and practice. She leads multidisciplinary inequalities research network and the international partnerships for equity and inclusion. And I would like to refer the audience to all the biographies because there are many more platforms that you are part of, Ghazala. So sorry for that. Laura, for you, you are head of the Department of Mental Health and Prevention at the Trimbos Instituut, the Dutch National Knowledge Center for Mental Health and Addiction. You're also director of the WHO Collaborating Center for Mental Health Services and Interventions across the life course. And your areas of interest are in public mental health and social determinants of health and social and health policy. And you will talk to us about the mental health impacts of COVID-19. Laura.
Thanks very much, Caroline, and good afternoon, everybody. I'm very happy to be here today to speak to you about something that's been on a lot of our minds the last months, which is COVID-19 and mental health. And early on in the pandemic, it was often referred to as the great equalizer in that it affected us all. And while we have all experienced effects and to a certain extent mental health effects of the pandemic, we continue to see data actually showing the opposite of an equal experience. People with social and economic risk factors continue to be hardest hit by the virus, the measures to contain it, and the resulting economic crisis. Why do we need to talk about mental health now? So measures taken this year to curb the virus and the economic impacts have already had results on educational attainment, on underemployment, unemployment, loss of income, and poverty is projected to increase in the coming years. We do have decades of research showing us the association between economic and social risk factors and poor mental health, and this is no different now with the current pandemic. And as Nico mentioned earlier, we also have research from the prior 2008-2009 financial crisis showing us that mental health inequalities widened and also impacted other important health indicators like life expectancy. So if we want to come out of this crisis mentally well and prepared for the challenges that lie ahead, we need to intervene on the social and economic risk factors rather than just focus on mental health within the health sector alone. So what mental health impacts are we seeing from the pandemic? There's been a lot of research happening in different countries via surveys. And in countries like here in the Netherlands, France, and England, we see that a large proportion of the population had elevated levels of stress, depression, anxiety, and sleep problems. However, symptoms did decline 3 or 4 months later when lockdown measures were eased and people acclimated more to the challenging circumstances or identified new coping mechanisms. This didn't necessarily go down to the pre-pandemic levels in terms of mental health status, but did decline. So this shows a little bit more resilient of a population and also confirms what we know from prior research. It's important to note that also for the general population, the decline in mental health symptoms is not likely to have warranted a clinical diagnosis per se or requiring specialized care, but it does require attention and support. And this isn't really the whole story. So there is a part of the population that has not been doing well during this pandemic and facing social and economic risk factors, or have felt a loss of control over their circumstances, or have existing health or mental health issues. And I think there's something we can do. So I think we need to develop short and long-term strategies because we're in this pandemic and the economic crisis for the long haul. And we need to focus on the whole population, so the generic population and mental health, and also specific strategies for vulnerable groups. Now, the mental health field has historically been more focused on the individual's role in changing their mental health outcomes, and we've paid less attention to the structural determinants that produce mental health and well-being. And I think if we're going to focus more on the whole population, we need to focus on social and economic policies such as income supports, which have been critical for many of us during the pandemic. As I mentioned, research has shown a big association between income, poverty, and mental health. And there's also emerging evidence, which I think Nico will speak to later, on the impact of social and economic policies on mental health outcomes like depression. We also know that there are societal returns from investing in population mental health, like long-term economic growth, a big discussion in this week's conference, productivity, and also political stability. So within this lens, actually an economic policy is a form of a mental health intervention. And the benefit of operating in this lens is that you're able to benefit the whole population, but also benefits for vulnerable groups. I think the second focus area is on community resilience and on community interventions that have been really powerful during the pandemic. There are quite some good examples of community integrated mental health and social care programs that address these social and economic stressors as a way to improve mental health outcomes like social isolation and loneliness, for instance. And these programs can also help improve public trust, civil engagement, and social cohesion, which are the very phenomena that have been threatened by the pandemic the last months. I think these programs can also help people regain a sense of control over their circumstances, feel more economically secure and productive, which are important determinants of our mental health in the long run. So in short, I think the mental health consequences of the pandemic and economic crisis have already started to show, and we'll see that impact back to an even greater extent in the months and years to come. We know that investing in mental health has economic and social returns, and we really need to make sure that we not only involve the health sector in devising strategies, but also employment, the labor, social, agricultural, and economic sectors as well. If we act now, I think we still have a chance to recover from the pandemic and prepare for future challenges with buffers in place that keep us resilient to these faceless stressors. And I look forward to discussing what some of these buffers are in the discussion. Thank you.
Thanks a lot, Laura, for your important presentation on highlighting the importance of mental health. For the audience, you can ask your questions. I've been receiving a few questions. One first for Nico. We know now quite well that there are inequalities due to COVID and a lot of research is being done. But do we need more research on this? And to what extent can research change or inform the strategies of governments on, mitigating the increase of health inequalities due to COVID-19 pandemic?
A good question. When you ask a researcher, is more research needed? They will always say yes. But it's totally clear that we need results now. And I said we have evidence on social inequalities in COVID-19, but I should say only from a small number of countries and with a limited number of studies. And many studies, in particular at the beginning, were ecological studies. For instance, we saw in different regions of New York City, they found a correlation between poverty and COVID-19 incidents, but those studies are just first signs that there is a problem. I guess we need individual level studies to really describe who is at risk and to precisely describe the vulnerable groups. It's not enough just to say it has something to do with poverty. I guess we have to properly define those groups, and Ghazala already made some very good suggestions. So I guess we need more research on a better description of really high risk groups, and then we have to understand the mechanism. So why do we see higher numbers of infection in certain groups? We don't really know why, and we don't really know why the case fatality is higher, for instance. It can be that pre-existing disease plays a role, but the evidence is a bit confusing at the moment. And so I think when we learn more about the mechanisms, so where do poorer people get infected? So this can help to design the right and targeted measures. I think that's an impact that more research can have.
Yeah. Thanks for that. Maybe Ghazala can already highlight from other kinds of experience and evidence how COVID-19 is impacting Black and minority ethnic groups, and then mainly on the micro level. I mean, you talked about the systematic discrimination as an underlying factor, but at the micro level, what is happening there that provides the evidence that we need?
So I think at the micro level, what we're seeing are socioeconomic disadvantage is a huge issue. And I suppose what I was trying to say, that the micro level outcomes of social exclusion are risk factors for COVID-19. So socioeconomic disadvantage is associated with higher rates of mortality and higher rates of illness. Historically, that has been the case, and we're seeing the same thing now. And then within minority ethnic communities, there are comorbidities, so diabetes, coronary heart disease, cardiovascular disease, that these are risk factors for worse outcomes from COVID-19 as well. And then overcrowded housing, these issues, homelessness. I think access to information about how to prevent and how to manage, if you actually catch the virus. How to prevent yourself from catching the virus. Often the information at the beginning was not translated into other languages. People's health literacy is an issue. Digital inclusion is an issue. And then actually a huge mistrust of services, just because often the quality of service that people get can be much lower than in the majority ethnic population. So I think, that often there are sort of explanations. There was a lot of focus on vitamin D deficiency at the beginning as a huge factor. But if you look at the evidence on that, it's not really very strong at all. It's quite mixed. And there is much more evidence for these kinds of factors that are more about the outcomes of social exclusion. So if you start talking about making it safer for people in public facing jobs, lower status jobs that are more exposed to risk, you haven't actually done anything about the structural issues that mean that risk is actually unfairly distributed across the population.
Yes, you're totally right. Thanks for that. And now my third question is actually one from Cara Price. And she wonders about students and children and with students in particular. So how are they impacted by COVID-19, and how has that impacted their mental health? I mean, is there any evidence, Laura, of the mental health of our young people? Because they are suffering not only from COVID, but in particular from the mitigation measures too, because so many things that are used to they can no longer do. So please.
Sure. Indeed, that's an extremely important group of people that have really suffered from a mental health perspective during the pandemic. And I think there are a combination of things that haven't helped. So one is indeed social interactions have been stunted and reduced dramatically in a period where social and emotional development is so important. Also, the governmental measures in a number of countries have been rapidly changing to account for changing circumstances. And that's also meant uncertainty for young people about when they can go to school, when not, what extracurricular activities are possible, what not. And I think last but not least is the future is uncertain, and there's a lack of perspective and clarity about what can be expected next. And that's in relation to their education, but also their future job opportunities. So I do know that there's quite a lot of studies happening, at least in Europe, on the mental health of students of different age categories, and a number of programs that have been focused on online classroom interventions to take what was originally done in person online, that focus on socio-emotional coping abilities and how to build that among different age groups. And there's also been some interventions focused on teachers and equipping them with skills to help students during this time, and also for parents. So I think there are a number of interventions that are effective, and we keep seeing emerging data from the pandemic about how students' mental health is during this time.
Mm-hmm. Thanks a lot, Laura, for your answer. So now I would like to thank Nico, Ghazala, and Laura for your presentations and your discussion. And I would like to hand over to Tim to moderate the second part of this session. Tim, the floor is yours.
Thank you, Caroline. Well, that was really fascinating, and actually a nice link there from what you were saying, Laura, about the kind of interventions that are being developed for young people. because this next session is really focusing on how we can, what the solutions might be. How do we recover, and how do we build into the recovery from COVID measures that might actually systematically change the health inequalities which have been entrenched for a very long time. So I'm going to turn first to Pilar, who is the Director General for Public Health at the Spanish Ministry of Health. And she's going to talk to us about advancing intersectoral solutions at a policy level. Pilar was previously the Director of the National School of Public Health. She's a clinician, as well as an academic, as well as having her position in the Ministry of Health. And she has a lot of research interest and experience in infectious disease and how that applies to global health. So really a wealth of experience to draw on. I'll hand over to you, Pilar.
And good afternoon, everyone. And I would like to thank the possibility to participate in this forum. You know that it's a very difficult time for us now in Spain, and especially being a director of public health. But for us, it's very important the matter, the inequities that I think, as all we know, this pandemic show us the map of the vulnerabilities in each country. In fact, we know that COVID-19 is having a great global impact, but this impact is having an unequal distribution through the population. And we differentiate three types of vulnerability. On one hand, we have the clinical vulnerability, we all know, linked to some individual characteristics as age, cardiovascular or pulmonary diseases or whatever. But beyond this, the evidence is showing us that there are also situations of greater vulnerability that imply a higher risk of infection or more difficulties in implementing preventive measures or isolation and quarantine measures, as for example, situation of precarious jobs or housing. That's what we call epidemiological vulnerability. These two types of vulnerability are interlinked with social vulnerability. People that live under circumstances and conditions of social vulnerability are suffering more the pandemic in three ways. At population level, they suffer from a worse health status and can suffer more clinical vulnerability. Their circumstances can imply more epidemiological vulnerability, and the control measures taken are having an unequal distribution along the population, worsening and creating new contexts of social vulnerability. This pandemic has shown, if included, what we already knew, the impact of social determinants of health. Thus, if it is a priority to analyze these vulnerability situations and to take measures with an equity focus and an intersectoral approach with the principle of leaving no one behind. In this sense, we are working in Spain in this aspect from different ministries with this intersectoral approach. And I would like to explain more in detail what we are doing. Since the beginning of this crisis, different social measures were put in place. Regarding employment, there are temporary employment regulation files which consist on a temporary measures that is taken when a business suspends or temporarily reduces their employer's contract. And during that time, the employers are protected with unemployment measures until they return to their jobs. These measures have been prolonged in time to continue covering this need. Regarding economic protection, different measures have been taken in different moments of the pandemic to protect families in situations of vulnerabilities, among others, to guarantee access to basic provisions, a social bonus that consists on a discount in the electricity bill for vulnerable households, suspensions of evictions, measures to guarantee food for children or vulnerable families, and other measures to protect children. Also, it has been reinforced all measures to protect women from gender violence. Along with this, the minimum vital income has been put in place in June. It is a benefit that guarantees a minimum income to people that do not have any. Also, education has been identified as a crucial element of society and for advancing inequity and health during childhood. As such, an agreement of all regions has been established to assure the reopening of schools, creating safe environments among COVID-19 to support people on vulnerable situations and the importance of school meals and canteens. Education and health sectors are working closely to ensure this priority. Regarding the impact of the epidemiological vulnerability linked to social inequities, we have been working, for instance, with the Minister of Health works with the Minister of Social Rights and 2030 Agenda in the strategy for residential homes for elderly. Also, in the next coming days, we will be publishing a comprehensive document that analyzes these aspects and gathers a series of recommendations that include general recommendations regarding the identification of situations of vulnerability, coordination, communication, reinforcement of health and welfare systems, and evaluation. A specific recommendation for preventive, detection and control measures, and intersectoral recommendation of structural measures to improve social conditions. In order to walk the pathway to recovery, also, the Spanish Congress has worked on the conclusions for a social and economic recovery with more than 200 proposals on employment, policies, finances, healthcare, and public health, among others. In conclusion, I consider that in order to go forward, we need equitable responses to this crisis, working on 3 levels: on the development and implementation of epidemiological measures so that their impact in social inequities can be reduced or tackled; on the evaluation first of measures and policies with the goal of adapting them and preventing the unequal impact they may have in addressing the social conditions that generate inequities. These responses require a coordination of all the different areas of health and all sectors. Thank you very much.
Thank you, Pilar. And you covered a huge amount, I think, in a short time there. It's really interesting to hear the breadth of the response in Spain, both now and for the future. So thank you very much for that. I'm going to move on now to Bart van Herke, who's the director of the European Social Observatory. And he's going to talk to us about mitigating the socio-economic consequences of health and economic crises. And I think we've probably heard about some of that already from Pilar in the Spanish context. Bart is, he's been director of European Social Observatory since 2010, and his research focuses on social dimensions of European economic governance. He's the lead author of an annual book on social policy in the European Union, which sounds absolutely spot on for what we're discussing today. So I'll hand over to you, Bart.
Okay, thank you very much, Chairman. You can hear me fine? Yeah. So yeah, thanks for inviting me for my first ever Gastein participation. I'm really quite excited about this, even though I would have preferred to actually be there on the spot, but let's see, maybe next year. So yeah, I thought it was good maybe when we have a discussion on how to build back better, or how did you frame it, how to pitch solutions in this very particular time frame, that we maybe start with a little reflection on what has already been done at the EU level. And you were so kind to refer to our annual book on social policy in the European Union, where we provide an annual state of play, indeed, of social policy making, and some of the chapters that of the book that will come out in a month from now obviously deal with this kind of issues. So let me just pick up a few issues related to initial member states and EU responses. I think it's fair to say that in the first weeks of the pandemic, member states, in fact, made very limited use of the tools that were available to them in the field of health. I won't enumerate them here. Many of the participants online, the speakers know them. So they didn't really use the tools that were available, but rather were seeking to restrict the flow of masks, protective equipment. And the focus was basically on safeguarding their national interest. And there was not a lot of European solidarity out there. Those were the first few weeks. I think it would be fair to say that when we look back now with a little bit of hindsight, this is a few months behind us now, what stands out is that quite quickly, in fact, after this initial period of confusion, of restrictions, of selfish behavior, we can say, that very quickly this gave way to quite significant coordination efforts, and indeed a public debate about strengthening the EU's role in health. So I think this would be, first of all, important to underline, and we see this quite clearly in a very ambitious EU for Health program that the Commission tabled. There's talk about a European Health Union now. The President of the Commission referred to this. And so it would seem that the Commission now really seized the space that the pandemic provided to start a debate on EU, on the role of the EU in health, and this in spite, of course, of the well-known weak legal basis, the low appetite of the member states that has been there forever, basically. So a second point I'd like to raise relates to EU and national ambitions, which have been quite important, I would say. After a difficult start, as I said, after the first weeks of the pandemic, we saw a quite remarkable demonstration of European solidarity. And this, I don't think that this has been highlighted very much. We all know in the meanwhile about the Recovery Fund. It is worth 750 billion euros, as we know by now. And if we add to that the increased EU budget, overall EU budget for the next 7 years, then a figure of 1.85 trillion euros comes up. Now, try to picture this. I'm a health sociologist myself, so I had to figure it out before this online session. A million is 6 zeros, a billion is has 9 zeros, a trillion has 12 zeros. So this is what we're talking about. The EU's financial power, what has been put on the table, is, at least for my mind, quite mind-boggling. And that's not the end of the crisis response. Of course, we know that one of the sacred cows of the European Union, the Stability and Growth Pact, has been put on hold for the moment. State aid rules, which have potentially an important implication for healthcare systems, have been relaxed. An instrument has been agreed upon called SURE to support the member states that set up short-term work schemes, and so on. So I think it's important to say that some unprecedented steps have been taken, which only 6 months or let alone 1 year ago would simply have been unthinkable. Unprecedented steps, which will continue to be tabled since the unprecedented economic crisis and its physical and health effects, to which Nico and Laura already referred, will remain on the table for the next few years. And then a third point that I would like to make in the few minutes that I have is contestation. Because, well, I said a lot has been done. I think what is being tabled by the EU and what has been approved by the member states is pretty impressive. But of course, the proof of the pudding, as always in politics, and especially so in EU politics, the proof of the pudding will be in the eating. The Commission, we know this story by now, was very ambitious to propose an EU for Health program with a much higher budget than we've ever seen before. And very quickly, these ambitions have been curtailed by the member states. And this is, of course, not a surprise. The EU's health competence has always been constructed through crisis and remains a contested territory, even in a context of this pandemic situation. Now, what I find important to underline is the following irony. Member states have indeed for decades been dragging their feet with regard to EU involvement in healthcare. which as a result, therefore, has mostly happened through the back door of the internal market. And now what is interesting and also slightly ironic is that what we see now is that the expansion of, the expansion of EU health competences, which is now really on the agenda, may in fact become acceptable to the member states precisely to safeguard the same internal market. Because indeed member states have started to realize that without a common EU health policy, there can in fact be no properly functioning internal market, which I think has been clear for researchers for a long time, and now at least some politicians are starting to realize that. I don't know if I have time for one last closing point, Mr. Chairman. On political... Yeah, very quickly. On political differentiation, I just want to add it because Pilar Aparicio and other colleagues already discussed the unequal impact of COVID within the population. Of course, we also know that at member state level, some of the hardest hit countries with regard to COVID have also those who have the highest level of public debt. And this raises some very, very tough questions, namely whether the large sums that are going to be available to lower income countries, which have been the hardest hits in some cases by COVID, will in fact be able to pick up that money and be able to spend this money on economic recovery within a very short time scale that has been foreseen. And so there will be some very tough discussions in spite of the agreement on a formidable amount of money on how to spend this money at the national level, and whether at some point we need to get back to some kind of balanced budgets, austerity, and all that. So we have some tough discussions coming on. I'll keep it at that. Thank you.
Thank you very much, Bart. That's really fascinating, and it sort of reminds me, coming from the UK, of how sometimes insulated we are from what's happening at EU level, especially nowadays. But really important things you've highlighted there. So thank you for that. I'm going to move on to our final speaker, Dana Borduja, who is a senior health economist at the European Investment Bank. Dana originally trained as a medical doctor, but turned into a health economist, so is in a good position to help us make sense of all those zeros that Bart was talking about. And her work currently involves the appraisal and monitoring of the bank's health projects and programs. So in a very good position to speak to us about this topic, which is investing in an inclusive, resilient recovery. So I'll hand over to you, Dana.
Thank you very much, and thank you very much for having us participating in this exchange and debate. I think it's not the usual invite, the European Investment Bank. I don't know if the sound was cut off when you were introducing, but it's not about me, it's about the institution. So I'm very happy to take over from Bart, at least from some of his comments, when he was talking about the EU solidarity, the instruments that the EU has available, the funding that the EU is trying to make available. Is it good or bad, enough or not enough? And also look at a little broader perspective or different perspective of equity at a society level, at national level, or at international level in terms of equity of access to healthcare in general. So coming back to where Bart left it, at least towards the end of his speech, we, the European Investment Bank, are calling ourselves the European Union Bank. So much of what we do is to support and enhance the EU policies and reactions, especially in times of crisis when not much liquidity is available. And it is the same case now with the COVID-19 crisis. So it was not unusual that even from the beginning of the crisis, the bank support had a whole of the society approach in line with the EU response. And our projects reach both economic resilience area and health sector. And these are the two that were on the spot most shaken by the pandemic. The health sector under enormous pressure at the beginning, and with the economies being at risk by mostly the lockdown and similar measures that were in every country. Just to give you an idea about the numbers, I mean, I cannot compete with the trillions that Bart mentioned, but I think it's still relevant that only during this year, starting with February, when the first measure were put in place, the bank was supporting with 77.7 billion this time euros the projects mostly in the COVID-related interventions, either emergency response or resilience building. So it's 77.7 billion, out of which 10.4 billion were projects directly related to the emergency response in the health sector, so about 12%. And again, out of the 77.7 billion, 45 billion went straight forward to the economic recovery initiatives. So when we also look at what my division, together with the other services at the bank, have in the pipeline for the next 3 months, it's about 8 billion of projects. And when I say projects, I want to be clearly understood by people that are maybe not so familiar with what we do, that we're mostly talking about loans. I think here I can make the point about the difference between the support from other sources of the Commission that come quick but for short term, and they usually put a pressure on the capacities of the countries to deal with this kind of sources of funding, and our interventions that are on purpose built for long term in order to give some space to the governments in relationship to their debts and balance. Just 2 or 3 more points maybe, because it's very, very difficult to come back to numbers, money, and financing projects after all the other interesting angles that we heard here. But still, we were able to react immediately. And when I say we are able to react immediately, an institution like the bank being able to adapt its own set of rules and regulation at the same time that discussions were held with different countries and partners for this support of projects and loans. It's something that we're very proud of, the immediate reaction. But also we try to build partnerships. And I think we heard several times today how important it is that these partnerships are channeled to the benefit of where the needs are, and in order to ensure equity. So what emerged in our discussions with the countries is that the immediate needs were, well, immediate, while the systemic issues that are already limiting access to healthcare just got revealed in plain sight or eventually got bigger. So that's what the pandemic revealed to us, at least through the eyes of our partners in different countries. And we clearly identified at least 2 main areas where access was disrupted or inequalities increased. One is, and it was mentioned before, the access of the general population to essential medicines and services. And this access decreased due to the quarantine, to the reduced capacities, facilities dedicated to COVID treatment only, shortage of staff, or outdated service models. And when I say outdated service model, I have in mind certain countries where the use of online tools for the provision of healthcare services was very low, and they had to immediately react and adapt, which was not possible, as we all know, without having a certain infrastructure and training in place. Another area that we learned that was suffering from equity of access was the access of national authorities to limited resources on the international markets. We all know that access to medical equipment, personal protective equipment, drugs, medicines, and now potential vaccines, it's very unequal. And it's in this sense that at least we at the IB try to foster, create, or be part of partnerships. So partnerships that will help sort out some of these issues. Learning by doing, we are now in the position to share some of these experiences with you, and still very high level. We want to listen to, and we did, to all the distinguished speakers of the day and cover a lot more angles than only what we are doing with the financing. And we try to invest in equitable and resilient recovery of health systems. And it's not an easy task, as it overlaps with the SDG 3 targets that we see somehow fading a bit away. But we will be suggesting that we need to partner within the best alliances, and we are currently doing it for vaccine development and production, for essential medicines and equipment stockpiling and distribution. We need to support health system at the roots, with primary health care being the basis of the pyramid. And this we try to expand and extend through a partnership with World Health Organization. We need to support innovation in and digitalization of the health systems. We all see that at least a part of this lack of access can be sorted out with the digitalization, but not only the access part. I think that the advantages of this have been discussed by people that know much more than me about it, and I think we're all familiar with it. And last but not least, working with partners and capitalize on team expertise. So we have Team Europe with the Commission. We work in a partnership with the World Health Organization. We're trying to have partnership with all the other agencies that are involved in areas that come close to our projects. And we also work closely with the private sectors, where they prove that they can have a significant contribution and bring the necessary standards. I thank you for your attention. I look forward for your questions and comments now during the meeting or on any time after. My contact information can be shared by the organizers. And I hope you'll all have a much nicer afternoon that we have here in Luxembourg with the rain. Thank you.
Thank you, Dana. It seems whichever country you're in today, it's raining. But that's really useful to get that. Thank you. I think we are quite a bit behind time, and we want to have a sort of panel discussion, but I'll maybe just ask two questions to the panelists here who've just spoken. And the first one, Pilar, is for you about whether you can say anything from Spanish perspective about impact on minority groups, and such as the Roma in your country. We've heard from Ghazala about UK perspective, but would really value your thoughts on that.
I think, thank you for the question. As you know, for us, all the Roma people is an important population in Spain. And since the beginning of the crisis, there were some, we need to talk a lot with all the organization and all the Roma people for one reason, because we have some important outbreaks related with some religious practice with Roma populations, and for that was very important for us to talk with all the leaders of this population, and we have several studies, and even in the middle of the pandemic, we did a survey working with one of the networks of Roma people. It's called more difficult than my name. It's XRCPEN. It's even difficult for us. But because it's a network of civil organization of Roma people, and we wanted to see how to deal with the problems of health promotion, the impact on health and education employment of the COVID situation. It was quite important for us. The survey was conducted in more than 500 houses. And some important aspects, as there was an increase in the perception of a poor health status during this during the lockdown, with the households experience very important problems related to, for instance, in education, as the digital, the e-learning was very important for that. And for many of these households, it was very difficult to follow all the education programs following that. There was also some problems with anxiety, as the houses, for the difficulties for the houses, it was not so easy to keep in the house. As you know, the Spanish lockdown was very hard. At the beginning, we couldn't go out of, except essential workers, as the Ministry of Health. Population couldn't go out of the houses except to buy the bread or something like that. And this was quite difficult for many populations. In that sense, this, I think, our experience to work very close with all these organizations and with the leaders was very successful. And in fact, the first important outbreaks that we have, we could manage to cut them, and during the following month, there has been no important outbreaks related with, that were involved these the Roma people. And then for us, this was a quite successful way to deal with that.
Thank you very much, Pilar, for that. I'm just aware of time, so I think we probably should move on to the panel discussion. I'm just going to mention a couple of really interesting things that have come up in the questions. One is from Clive Needle, who said, really interesting to hear about the expansion of EU competencies in health, but what does that actually mean for health and social equity? I think the other point that Bart has made to me in the chat is that we've talked quite a lot about income and socioeconomic status, and we've talked about ethnicity. We haven't said much about gender and the gendered impact of the pandemic. So it might be something we want to pick up in the discussion later. But Caroline, can I hand over to you now to chair the final part of this session?
Yes, thanks, Tim. So maybe indeed to follow up all the questions that you saw in the chat, which are very interesting from Clive, but also some others from Freek Spinnewijn, for example, and he is pointing out that in the USA they have come with a ban on housing eviction, which is an interesting measure. And such measure, do you know that is taking place also in Europe and countries? And what is the EU be able to do on housing? Because housing is such an important area. There are other questions, one from Marinella Pebu about the impact of COVID-19 on other people with other infectious diseases like HIV/AIDS and issues of stigma there. And there is a question from Nina, specifically around mental health and the intersectional perspective, and whether that needs to be better addressed. Maybe also one question I have for Dana on investments and financing. You talked a lot about, let's say, the biomedical approaches to the crisis and preparedness, and a lot of money goes into there, and that's needed. But is it possible to also get finance for more the psychosocial aspects of crisis preparedness? What we are talking about here on reducing inequalities and tackling mental health. I know the primary healthcare centers you talked about, but what else is it that the European Investment Bank can do here? In InvestEU, there is a fourth window on the social window. I mean, will that help in investing in more social responses to the crisis? So various questions have come up. Who would like to start? Bart? Yes.
Yes, thank you very much, Caroline, and thanks for introducing these very interesting questions. I'll just pick and choose a few of them, of course. First of all, Freek Spinnowend's comments about Europe for Health and whether it actually expands EU competences. I unfortunately, we agree, because it would be more interesting if Freek and I disagree on this point. I think this program is more about, let's say, intensification of existing areas of activity rather than creating new roles. So that's also not the role of an EU program, of course, not to extend competencies. It is about surveillance of epidemiological data. It's about funding research. It's about collective health security and emergency responses, these kind of things. It is a step further. It's a sort of a broader interpretation of the actual competences of the EU in the healthcare area without indeed creating new one, which would require more political agreement, of course. And maybe linked to this point, I think the discussion in general about the role of the EU, I don't think we should start dreaming, or at least I don't start dreaming of a treaty change that would all of a sudden give the EU lots more competences. Even in COVID-19 times, this won't happen. But we know, of course, that competences that are there can be stretched, can be interpreted in a more holistic way, and therefore lead to more competencies in practice. Clive Needle's question about healthcare and the internal market, maybe I didn't express myself very clearly. It's also not only raining in Luxembourg, but also in Leuven in Belgium. So what I try to say is that it's a bit ironic that member states now seem to accept a drive towards a more holistic interpretation of the role of the EU in health, because I think that this might help to save the internal market, just very practically, because it will impede, or it could impede, member states to take restrictive measures that indeed impede the functioning of the internal market. Will this benefit? Will this really benefit health and social equity? I don't know, Clive. I'm not sure. Maybe something very different is needed. For example, we know that during COVID-19 there have been huge issues with non-coverage for important social security risks. There are major gaps in social security coverage that have come to the floor, not only of platform workers, other kind of non-standard workers, but of important categories of the population, which especially in non-affluent coverage countries have just completely fallen through the safety net. If we talk about equity, then this is work where work needs to be done. I wanted to answer Freek's other question, but no, but I need to stop.
I would like to get back on the point on social protection floors and basic minimum incomes, and would that also be measures, Ghazala, for you, maybe this question, would this be measures that would help UK, the groups that you are representing and that you are talking about? Social protection, having a safety net, would that, in addition to addressing the structural discrimination, as the point was very well taken, but would that be a good direction to take?
Certainly, I think in terms of the economic impact and the economic inequities that exist, then a minimum income would be a really positive move in that regard. But I think that it's not, economic sort of interventions are not really enough. We need to look at, the question about whether the protection of the internal market would be alongside health equity issues. I think that raises an important point about who is actually making these decisions in terms of the policymakers within the EU, just as at national level within EU countries. The voice of people who actually experience exclusion is not really there. So, I think it's important that whatever interventions are looked at, there is the voice of people from these communities actually being represented, because otherwise, shifting power, challenging racism and discrimination is very unlikely to be a core sort of focus for whatever policies are adopted. In terms of, what really needs to be looked at, access is one issue, but representation is a key issue. And actually what outcomes across different population groups are being achieved through the policy. So what is the impact of those policies in different populations in terms of health and equity? And certainly within the UK, lots of national bodies that are looking at these sort of ethnic repercussions have said that there needs to be more accountability in terms of inclusion, because it shouldn't be just an issue of goodwill. We need the infrastructure, cross-government infrastructure, and maybe we're talking about cross-EU infrastructure that addresses the multiple drivers of inequity, because the policies that are actually hostile exist alongside other policies that could be helpful if they focused more on the issue of equity as a core kind of focus. So I think accountability and actually having the voice of people, representation, is what would help to change the cultures that actually create and maintain discrimination and embedded racism.
Yes, thanks for pointing it out. And maybe for the other speakers, I mean, the voice of the people. I mean, in Spain, how are you bringing them on board? Or in your mental health work, Laura, how are you listening to or incorporating people that are experiencing mental health problems? Or Nico, in your research, how are you able to capture the voices of these people? Maybe Pilar first from Spain. Oh, I think Pilar seems to be frozen. So Laura, back to you. Or Nico, who would want to respond? I
can start. So I mean, I think the mental health movement in the last, I would say 5, 6, 7 years has really been focused on incorporating the voices of people with lived experience of mental health issues as peer experts on, for instance, multidisciplinary community mental health teams, so actively involved in peer support and service delivery, in shaping policies and guidelines, clinical guidelines, and also involved in research. So at Trimbos, for instance, we have a user empowerment and service user research center in the Netherlands. There's a lot of in mental health care institutions and mental health organizations. There's often a very active peer support and peer expert network that meets with the board of directors and with other stakeholders to have a say in what's happening with the direction of the mental health service. And I think also in research, you increasingly see service user associations actively involved in consortia on research in the Horizon 2020 program, for instance, which I think is a really needed step forward to make the research findings that we have more relevant and more meaningful.
Yes, I know that the European Social Survey will now be incorporating health inequalities indicators in their survey, so we will be able to know more about that. Nico, how do you or how are you able to make sure you capture the specific needs of these groups in the research on health inequalities?
To be honest, I'm working at the moment with secondary data and epidemiological data. So we are doing kind of classical social epidemiology work. And indeed, there is not so much participation in this part of quantitative work. But there are many other colleagues which support the work with qualitative studies, and our part, we have a center for health and society in our clinic, and they wanted to found a panel of laypersons where you have representation of different societal groups. The idea was to do that this year in March, and therefore we don't have it yet because it was simply impossible. Mm-hmm. But yes, one could do more, especially those data people. I would consider myself as more a data-driven researcher.
Mm-hmm. Mm-hmm. Thank you, Nico. Bart, very short. Bart.
Yes, I'm unmuting my mic. Okay, no, very quickly, just to say that what we try to do with the European Social Observatory is regularly go out there to discuss research findings stakeholders. So that's not the same as what has been suggested, to talk to immediately with people concerned by poverty or health issues, but it is talking, let's say, with people, representatives of those communities. So what we do is talk with trade union representatives, business representatives, NGOs who represent themselves, these categories of people. So that's a way to find a middle ground in that. Can I just say 2 words about Freek Spinnewijn, because he responded to you, Caroline, about this eviction ban. So I think I think Freek Spinnewijn is totally right to say that such an eviction ban not only would be important, but he points to the fact that it can be motivated from a public health perspective. We know, of course, that discussing housing, homelessness for so far has been a no-go area for the European Union. What I see is that the new Commissioner for Social Affairs, Nicholas Schmid, is now using the European Pillar of Social Rights in a quite in quite a good way to put housing and homelessness on the European agenda. Member states are not very keen, very supportive of this, but he's doing his very best there. And I think that the tool that is out there, the European semester, would be a good place to start pushing on member states to give them some kind of guidance. Even though, of course, and then I'll stop, Caroline, we know, of course, that in the semester there are so many economic, social, employment policies. Now the Commission wants to add the Sustainable Development Goals, the Green Deal. All of this is going to be managed to the European semester, and my fear is that it will become a little bit of a Christmas tree again. But I agree, housing and homelessness should be part of it. Absolutely.
Yeah, very important. Housing, as COVID has demonstrated how important housing is. Dana, I saw that you muted briefly your, yes, so go ahead for your, I think, final statement. I'll do a round with final statements, and I'll start with you, Dana. Dana seems to be frozen. So maybe I'll start with Pilar. I give all of you one last opportunity in one sentence to share what you still wanted to say. So Pilar, the floor is yours.
For us, in this moment, it's very important to have this multisectoral approach. Our experience in this very hard moment for us is that not only we need to answer very fast to the first moments of when increase the number of cases of COVID, but also attend very specifically the more vulnerable people, and have with a multi-sectoral approach, not only the health approach, but also social and other kind of interventions.
Yeah, very important. Thanks, Pilar. Laura, would you want to?
Yeah, I think from my side, it's that mental health can't be considered only within the health domain. You really need to see from a public mental health approach that income security, there's a bidirectional relationship with income security, economic security, and mental health, which is critical during the economic recession now, that we need to really think about how that's going to change over time and develop strategies for. And that also includes housing, stability, and security, among other social determinants.
Yes, exactly. Thanks, Laura. Dana, you're back. This is the last round of, let's say, one further statement. Dana?
Thank you. I will just take this opportunity to answer your questions from a little bit earlier. What the EIB, as the EU Bank, is doing and is planning to do in terms of the building of resilient recovery and increased and equitable access, it's above the normal things that we do. And yes, primary health care, and yes, preparedness from the social point of view, everything can be included because the bank works with the partners, and the partners are the governments, national or regional. And I'm just giving the example because Pilar is in the meeting of having at least 4 programs for COVID-19 response with Spain, one with a general one at the country level, but 3 of them are at the regional level, Galicia, Navarra, and Madrid, for example. So we work with partners, mostly from the public sector, but not exclusively. So they are the beneficiaries of our loans or financing. So as long as the small actors that are usually in the social sector can team up together under a project. As you've already mentioned, even InvestEU has this in mind and will be one of the institutions that will put in practice the InvestEU and try to channel the money through the final beneficiaries. Thank you very much again for the invitation today, and it was brilliant to be able to listen to all of you. Thank you.
Thanks a lot, Dana, also. Ghazala?
Thank you. Yeah, just to respond to some of the comments that have been made already, I think the macro level kind of issues that are driving and creating and maintaining inequities are really important. And in response to Nico, I would say it's not just about people not participating. It's actually the sampling is not really including people. So the methods that are used to sample are not really taking account of diversity. So I think if people are not represented in these huge samples that are taken, then they're invisible, and then that is not going to inform any decision making. And the decision making is more likely to be focused on equity, as in response to what Bart was saying. This is not just about consulting with people, it's that the policymakers themselves need to be representative of the communities that exist within the European Union. So if the policymakers are actually from the majority population almost exclusively or primarily from that population and from privileged backgrounds, it's very unlikely that they will make equity a key sort of issue. And then in response to Laura, I just want to say it's great that you've got these infrastructures for consulting with people who have mental illness. And I would just say that the diversity amongst that population is something to take account of. And also, as somebody who works with, ethnic minority and other disadvantaged groups, I think it's really a time for us to make alliances with each other and for us as researchers to facilitate those alliances, because actually the majority of the population experiences disadvantage. If you take account of gender and and all the other exclusion groups that are excluded, they are the majority. So it's the time for alliances, and I think all those issues, we need to address these issues at various different levels and to look at it as a strategy rather than one or two interventions that would solve everything.
Mm-hmm. Thanks a lot, Ghazala. As the time is up, actually, we are running out. I would like to hand over to Tim now. Is it very brief on Bart and very brief?
Well, you said one sentence. My one sentence is that we forgot one elephant in the room, namely the gendered impact of COVID-19. COVID-19 has done a lot to push fathers to take on care responsibilities. We know this from initial research, but women, of course, have been far more at risk because they work more in the service work, etc. And so I think it's about time that the EU takes its gender equality streaming policies very, very seriously. One sentence.
Yes, very important point, Bart. Nico, then do you also have one more sentence you would want to conclude? And then I'm fair to everyone. Yeah, Nico?
Yeah, very short. Ghazala said a very important thing. When we look at the 2008 crisis, there were many people who said that research is not prepared for capturing the social impact of such a crisis because we didn't have the proper data. And there were many papers at 2008, 2009 that said after this crisis, we need to set up the right systems to measure the social impact of a new crisis. And I'm not sure if that happened. I'm sure that it didn't happen. And maybe we make it better this time to have better data for the right decisions. Thanks.
Exactly. Thanks, Nico. Tim, over to you.
Well, I'll be very brief. I mean, it's been a fascinating discussion, and I just want to thank all of our speakers. It's been such a rich range of perspectives and areas of expertise that there's so much to think about in there and so much to get on with. I won't try and sum it all up, but it has been fascinating to hear just the magnitude of the problems and the challenges ahead. But also the energy and the expertise that is available. And to me, I'm actually feeling optimistic in a sense after this session that there are opportunities coming out of this crisis to address some very long-running structural issues. Although it's obviously a very hard time the building back better has become a slogan, but I think there is something in that, and some of the ideas that we've discussed today, I think, could be part of a genuine recovery that tackles inequalities that we've been working on, many of us, for a very long time. I think we better stop there, Caroline. But thank you to everybody. It's been fascinating, and thank you to everybody who's been listening. And I know there's been technical trouble, so thank you for persisting and giving us your questions and being part of today's session. And wherever you are, whether it's raining or not, I hope you enjoy the rest of your Friday.
It's also frozen, so I can finish there. Thanks a lot, Tim, very much. And thanks to all of you, to your great contributions, and to all of you also listening. And I really would like to thank my colleague, Alma Godfrey from EuroHealthNet, who has put this session together, and the Gastein organizers, Lisa and others who are also with us here today. So thanks a lot, and hope to see you soon at other sessions, probably online. Okay, bye-bye.
Bye.